Okay. Thank you very much, Mr. Chairperson, ladies and gentlemen. It is my great honor to have an opportunity to present at the World EP Forum in Seoul. I appreciate to the organizing committee. My disclosure information. To prepare this presentation, I asked ChatGPT what are the major issues in atrial fibrillation catheter ablation. It provided these potential issues: success rate, complication, recurrence, procedural limitation, post-procedural arrhythmia, and operated experience. It seems to cover the key aspects. Then I asked to myself and my colleagues what additional major issues could be proposed. These answers came out: socioeconomic difference, healthcare system, training system, language barrier, and inequality. Now, let's think about issues presented by AI and human intelligence. This is first major issue in AI ablation success. This is Kaplan-Meier curve for AF recurrence after ablation in my institute. In over 5,700 patients experience, 1 year outcome is pretty good, over 87% success in approximate fit. However, as patient gets older, AF recurs continuously like this. I think the first AF recurrence 5 years after de novo procedure might be AF progression. Although we can manage the atrial fibrillation somewhat by catheter ablation, it is not a curable disease. Looking at recent RCTs, most RCTs to find out the empirical extra PB lesion set better than PB isolation showed negative outcomes. Regardless of proximal or long-standing persistent AFib, linear ablation, posterior box isolation, and late gadolinium enhancement ablation did not show any superior results compared to PBI alone. Of course, a few positive RCTs shows a superior result compared to PBI alone. Low voltage area substrate ablation and hybrid convergent procedure improved the persistent AFib outcome. And the small RCT shows that extrapulmonary vein trigger ablation and SBC septal linear ablation and renal denervation improved the rhythm outcomes. In this study, we analyzed the characteristics of patients with first recurrence after 5 years after de novo procedure, and upper panel patient recurred atrial fibrillation 7 months after the procedure, and the low patients recurred first recurrence after 7.6 years of de novo procedure. The patient with first recurrence after 5 years generally had a low LA voltage but small LA size at de novo procedure, and this group of patients with very late recurrence showed a significant improvement of left atrial voltage at redo mapping. And another characteristics of these very late recurrence patients was rate of extrapulmonary vein trigger increased remarkably under redo mapping. So it suggests that although PBI was well maintained, extra PB triggers by AF progression may have contributed to recurrence mechanism. We compared the redo mapping findings depending on the recurrence timing within a year, between 1 and 3 years, and after 3 years. Smaller number of PB reconnections as later timing of recurrence after de novo, but more common extra PB triggers a later timing of recurrence. In this study, we found extra PB trigger in 12% of de novo, 29% of redo mapping, and over 30% of extra PB foci at redo procedure matched to previously done empirical ablation sites. So a necessary extra PB ablation at de novo potentially contributes to the recurrence mechanism. As you expected, the rhythm outcome was worse in patients with extra PB triggers in both de novo and repeat procedures, and it was even worse in patients with multiple extra PB triggers than in those with single trigger. Next issue is complication risk. We know the AF ablation complication risk is high in women, especially elderly ladies. In this study, major complication and cardiac tamponade risk were significantly higher the ladies older than 75 years old, and it was because left and right side the PB antral wall thickness were significantly thinner in those older ladies at CT scan. And Corner score is a standard score for malnutrition composed of albumin, cholesterol, and lymphocyte, etc. In this study, 0.4% of patients out of 3,200 AF patients had moderate to severe malnutrition, and we found a significantly higher overall and major complication risk in patient group, especially in female patients with malnutrition. Therefore, we have to be careful during the procedure for patients with small body size, malnourished old ladies. We found that AF ablation increased the left atrial pressure at the repeat procedures, especially in patients who underwent empirically done extra PB LA ablation. And we measured the 1-year follow-up echo in this study, and the stiff LA physiology defined by echo follow-up data was observed in 3.7% of overall patients. In this study, we found hyper short duration PBI significantly increased the long-term symptomatic PB stenosis up to 0.4%, especially in young men with proximal PB. Esophageal fistula, the most catastrophic complication of AF ablation, seems to have almost disappeared as we do esophageal temperature monitoring. In this RCT, esophageal temperature monitoring did not reduce endoscopically detected esophageal lesions statistically, but the absolute number was very small in the monitoring group. And the risk of esophageal damage significantly increased when the esophageal temperature exceeded 42 degrees. The following is technology issue. In the last 5 years, single-shot balloon technology and PFA, pulse field ablation, have come out and greatly affecting the PBI market. Hyper short duration PBI, which was introduced 4 years ago in Korea, did not improve the rhythm outcome compared to conventional RF PBI, but significantly shortened the procedure time. And CRAFT trial was the RCT comparing hyper short duration PBI versus cryoablation PBI. Again, there was no improvement in rhythm outcome, but the procedure time was further shortened. This is a retrospective comparative study of cryo PBI versus pulse field PBI, recently published by Frankfurt Group. And consistently, there was no difference in rhythm outcome, but a PFA PBI further increased the procedure time. So the PBI outcome is similar regardless of energy source, but the recently released device reduced the procedure time significantly. It is nice to see less operator-dependent and efficient technology, but it is unfortunate that the AF catheter ablation outcome is still stagnant in spite of increasing medical costs. AF has a significant genetic trait. Now genetic traits should be considered. And let me introduce our recent 3 studies related genes. And the first one is left common trunks PB, has genetic background, and also has a thicker antral wall and higher chance of recurrence after catheter ablation. 5-year follow-up after AF ablation in patients with significant sinus node dysfunction. 15% eventually needed permanent pacemaker, and those patients have a genetic background of sodium channel and the gap junction. And the genetic risk of zinc-finger HOMBOX3 gene, the top second AF-associated gene related to fibrosis, was also significantly higher in patients with proven extra PV triggers. So it is time to evaluate genetic traits affecting AF subtypes. Along with gene, AI and digital twin must be considered in the next generation AF ablation. In this AI study, we aimed to predict rhythm control failure, rather than a 30 seconds cutoff recurrence after ablation, and we generated the STAR score to predict the rhythm control failure by conventional statistics in over 5,000 patients, and the trained machine learning prediction model. And the AI prediction model calculated the risk of AF ablation failure without invasive variables and achieved the excellent risk stratification with reasonable AUC values. Finally, AI model successfully predicted the high-risk group of AF progression in the independent cohort 2. Therefore, using the pre-procedural and non-invasive variables, the AI prediction model can identify patients at high risk for progression to permanent AFib before the ablation procedure. So based on this study, we are conducting randomized clinical trial to test whether AI-guided patient selection for atrial ablation catheter ablation improves the rhythm outcomes. Digital twin might be another next-generation AF ablation technique to consider, and the real-time digital twin calculation during AF ablation procedure became possible now. And using the electroanatomic mapping data, digital twin localized the area of extrapulmonary vein AF driver targets. And we previously showed that digital twin guided dominant frequency ablation improves the persistent AP ablation outcomes. And the RCT of digital twin guided phase singularity point ablation is currently progressed to as a randomized clinical trial. So far, we have summarized the major issues of AF ablation, including cutting-edge technology. However, AF ablation included in well-designed study may completely differ from real-world practice. What are the major practical issues regarding AF ablation in Asia-Pacific area? This data is the number of AF catheter ablation from 2018 to 2021, cited in APHS White Book. And China caught up to Japan and took the first place in 2021. On the other hand, the AF ablation number in other countries are rarely seen. So cutting the y-axis down shows that Korea, Taiwan, and followed by countries still showing very low number compared to China or Japan. So what about the number of AF ablation per population? And Japan has the highest number of AF ablation per population, and Korea ranks second. If you zoom in, you can see Singapore, China, Taiwan, Hong Kong, Malaysia, etc. But other Asian Pacific countries still show extremely low numbers. Sadly, we do not have data on North Korea. Each country's economic power, healthcare system, and training system may influence these marked differences. In spite of each country's condition, the differences and inequality in AF patients benefiting from ablation are too significant. Don't you think this issue is more important than just 10-minute procedure time reduction or genetic screening? These are the global distribution of GDP and Gini coefficient, an index of inequality. Although GDP of Asia Pacific countries is lower than that of US or Europe, GDP growth rate was significantly higher in Asian Pacific region. Surprisingly, Gini coefficient in AP countries were better than United States, but not Europe. So this suggests that with increase in economic power, more AF patients in AP area can benefit from catheter ablation. This is a summary of AF catheter ablation issues in Asia Pacific area. Each country has a socioeconomic difference, healthcare system, training system, language barrier, political issues, and also inequality issues. Nonetheless, economic indicators point to the possibility of doing better than now. Then, what can we contribute to this now? We KHRS have been committed to global EP physician training, and in 2016, Professor Young Kim announced the Asian Pacific country-to-country matching step-up program at APHRS, and about 35 overseas fellows received the formal EP training in Korea and returned back to their home countries. And KHR's International Service Committee volunteers visit the EP labs 3 or 4 times a year to support education or donation of equipment and catheters. So our mission is to establish self-reliant human resources in these developing countries who can organize future medical system and provide appropriate EP training independently. I hope that our volunteer support will be a small contribution to resolving the arrhythmia issues in AP region, and we sincerely thank their dedicated APKHRS members. So in conclusion, ladies and gentlemen, atrial fibrillation is not a disease, but a curable disease, but a progressive degenerative disease. Extra PV triggers are significant determinant for the long-term outcome of ablation. Unnecessary more touches increase the risk of extra PV triggers. Malnutrition and older ladies are at risk of complication. High pressure duration RF prior first bill did not improve AF catheter ablation outcome, but shortened the procedure time. Genetics, AI, and digital twin will play some roles in patient selection or extra PV ablations. Our imminent task to resolve global inequality might be education. Thank you very much for your attention.